blood system in pediatric medicine. This lecture will focus on anatomophysiological peculiarities of the blood system and interpretation, evaluation of the basic screenings. Information about the lecture. Let's begin with hemopiesis. To start off, one of the main processes that creates the blood system is hemopiesis. It is the formation of blood cellular components. Daily, up to as much as 10 to the 12 new blood cells are produced. Everything begins with the multipotential hematopoietic stem cell, or hemocytoblast. It can divide into two types of common progenitors, the common myeloid progenitor and the common lymphoid progenitor. From that stems the rest of the cells. We have the myeloid megakaryocytes, which stays inside the bone marrow, producing thrombocytes or platelets. We have the production of erythrocytes, mast cells, and myeloblasts, which go on to produce basophils, neutrophils, eosinophils, and monocytes, which enter tissue and become tissue macrophages. The common lymphoid progenitor produces NK or natural killer cells, and small lymphocytes, which mature to T lymphocytes or B lymphocytes. B lymphocytes undergo further maturation to become antibody-producing plasma cells. This is the brief overview of hemopiesis. Here on this slide, you can see a more detailed process. Observe that the hemopoietic process requires various cytokines like interleukin 1, 6, 7, 3, 5, 4, etc., and various other factors in order for the precursor cells to mature into the final forms. Of course, that implies that there can be disruptions to the cycle at various levels, including possible disruptions that we ourselves can stimulate pharmacologically. So the understanding of this mechanism helps us in both diagnosing problems and finding pharmacological targets. One of the main tests that is performed to analyze the state of the blood system, which in turn helps us evaluate the patient's condition, is the peripheral blood count, also known as the general blood analysis or the complete blood count, or CBC for short. The blood for this analysis can be taken from a finger, because it can be done using capillary blood, or it can be taken from the vein. This is an important screening method for all medical conditions. It is used everywhere in the world because it is relatively cheap, fast, and virtually non-invasive. As again mentioned, can be taken from a finger. The reference values, the norms, vary with age and later with sex of children. Let's take a look at some of these reference values. Now, the reference values presented here are sort of mid-range averages taken from multiple sources. All of them are proven medical sources. I'm taking an average reference values. We have, for reference values, children that have just been born in the first 24 hours of life, children on the fifth, sixth day of life, infants roughly 1 month old, infants 1 year old, preschoolers about 5-6 years, and school children of about 12 years. The values that we look at in the general blood analysis or the complete blood count include, but are not limited to, the following: erythrocytes, the RBC, the red blood cells. As you can see, that this number is quite large at birth. This is due to the large quantities of small erythrocytes packed tightly with fetal hemoglobin, which is necessary for intrauterine life. But this number quickly begins to diminish in the first days of life, leading to quite a low amount at the age of 1 month, where I took an average reference value about 3.3, although multiple sources indicate an average reference value between 3 and 3.5, which is technically below what is considered to be a physiological norm, which is 3.5. That implies that children of this age have a slightly lower erythrocyte count than would be considered physiologically normal. If their hemoglobin count is also decreased at this age, we can talk about what's called a physiological anemia, transitory physiological anemia of children. The numbers starting with the age of 1 pretty much stabilize and remain more or less the same for the rest of the ages. Mean corpuscular volume, MCV, is the volume of the erythrocyte, which begins with usually slightly larger erythrocytes because they're tightly packed with fetal hemoglobin. Then with time, the more erythrocytes with fetal hemoglobin become destroyed and replaced by alpha hemoglobin containing erythrocytes, the smaller they get. And roughly closer to the age, after the age of 1 month, so somewhere around the age of 4 or 5 months, the erythrocytes have their peak smaller numbers. Possibly also peak smaller erythrocytes and definitely peak smaller hemoglobin, which can reach in that time period about 103, 104, which is the peak of our physiological anemia. Caused by the depletion of all the reserves that the child has gotten from the mother in the last months of pregnancy. Hemoglobin also begins very high, again, due to the fact that it's fetal hemoglobin that's being measured, and as it's being replaced by alpha, the numbers tend to drop. Color index, we'll take a look at how that's calculated in a moment. Shows the relationship between hemoglobin and erythrocytes. Other parameters besides color index do also exist. We have the MCH and MCHC, which in a lot of automated counters, hem analyzers, have begun to replace the color index. However, the color index is a parameter that can be calculated, not measured, and therefore, despite the fact that it would not be given on a printout, as long as you have your erythrocytes and hemoglobin, you can always calculate it and make appropriate conclusions as to this particular number. Again, the erythrocytes are more packed with hemoglobin after birth, so the numbers can be higher. And with age, these numbers slightly decrease and normalize after the age of 1 to the parameters that most adults would have as their normal reference values. Hematocrit, a concentration of various elements inside the plasma. Obviously, again, in the first days of life, lots of erythrocytes, so the cellular elements are more than the plasma content, but with age, this number decreases where the plasma becomes more than the cellular content. Reticulocytes are young forms of erythrocytes, which come out only in times of intense erythrocyte regeneration inside the bone marrow, and of course the physiological hemolysis taking place after birth of erythrocytes containing fetal hemoglobin, meaning more reticulocytes may possibly be present inside peripheral blood. Thrombocytes or platelets, they roughly stay at a fixed set number throughout your lifetime, having a fairly fixed reference values. Erythrocyte sedimentation rate is another parameter that can be measured, and it stays fairly small for infants, and then gradually reaching its adult characteristics of possibly being slightly higher in older age. This is relevant to various factors, including the amount of cell elements, the hematocrit, and multiple other factors that exist. This can be definitely used for evaluation and will be. We'll talk about this in detail. Next, we'll move on to the white blood cell count. And here we see the leukocytes, the WBC, the white blood cells, as being 9 to 30 on day one. Pretty high number considering, but this is mostly in relation due to non-specific stress response. Birth is stress, and the child manifests these high numbers mostly due to the neutrophils coming out of depot. As the depot becomes depleted and exhausted, the segment neutrophil numbers continue to drop, and by the time we get to 1 month, or even much earlier than that, we get the normal infant blood, which contains more lymphocytes than neutrophils. And that stays true until the age of 5-6 years, when this situation becomes reversed and neutrophils begin to increase, together with the resistance towards bacterial infections and lowered resistance towards viral infections. And of course, in children of school age, you can see that the neutrophil count is higher than the lymphocyte count. The basophils stay roughly the same throughout, except in the first few days, as these granulocytes can come out of depot together with neutrophils. The eosinophils, on the other hand, are staying extremely small after birth and then normalizing by 5-6 days to their stable amount that's going to exist for the rest of the life. Monocytes, same thing happens with monocytes. Stress response, more of them come out, and their number gradually decreases and normalizes by after the age of 1. Neutrophils are typically separated into their subpopulations according to their age, segments being the oldest. Stab neutrophils or band cells, young cells, which are also referred to as metamyelocytes, and myelocyte cells. Normally, they should be absent inside peripheral blood. There may be one lone metamyelocyte present in the percentage formula. Stab neutrophils or band cells stay up to as much as 5%, except immediately after birth. Okay, so we already started talking about this a little bit, but let's focus on it some more. We have the leukocyte crossover. The leukocyte crossover. This is the graph representing the population of neutrophils expressed in the bold line, and the population of lymphocytes expressed in the dashed line versus age. The first presented are the 12 days, then following the months, and then following the years. So again, the child after birth has antiviral immunity for the most part and low resistance towards bacterial infections. He has much higher count of lymphocytes than neutrophils. However, immediately after birth, I mentioned the stress response and the exit of neutrophils from the depot, which quickly are exhausted, and by the age of 5-6 days, we have what's called a crossover. We have roughly the same amount of neutrophils and eosinophils. Of neutrophils and lymphocytes. And then eventually the immune system matures and starts resembling that of an adult. At the age of 5, 6 years, we get a crossover, the second crossover, that represents the actual maturation of the immune system, unlike the first crossover, which is simply a depletion of the depot of neutrophils, and the immune system starts to mature. And by the age of 12, we get a more or less adult immune system ready to fight and resist bacterial infections, but no longer able to resist the viral ones. So it's much better when a child has his viral infections during his childhood period before school, because after, he will not respond to them as easily, having a higher chance of prolonged clinical course and complications. Okay, let's look specifically at each parameter of blood and talk about what can cause the elevation of these particular cells and the reduction. So for erythrocytes, increased number appears in situations of dehydration, high altitude residence, such blood tumors as erythroblastosis, and such chronic hypoxia situations as respiratory failure or heart failure. Reduced number appears in anemias or acute hemolytic conditions, poor nutrition, large hemorrhages, leukemias, and hereditary pathologies. Hemoglobin increases in dehydration, congenital lung or heart disease associated with severe hypoxia, chronic hypoxia, pulmonary or heart failure, pathology of kidneys or hemophilia. Reduced hemoglobin appears in anemias, leukemias, deficiency of iron and certain vitamins, example would be like B12, exhaustion, and large hemorrhages. Color index is elevated in anemias, such as B12 and folate deficiency anemias. These are called hyperchromic anemias, dehydration, heart failure, or respiratory failure. Reduced in renal insufficiency and in anemias such as iron deficiency anemia or thalassemia. Platelets or thrombocytes, elevated in inflammation, anemia after surgery, oncological disorders, physical exhaustion, reduced in congenital blood diseases, diffuse diseases of connective tissue such as lupus erythematosus, various infections, anemia, hemolytic disease of newborns, as more of a complication where we have an isoimmune thrombocytopenia, blood transfusion, heart failure, basophils, elevated for chickenpox, allergies, nephritis, anemia, hormonal drug administration. Noting that we do not have a reduced number since the basophil concentration count could be 0. That would be acceptable normal. Eosinophils, elevated, allergies, parasitic diseases, infections, oncological processes, blood disorders, reduced in intoxication, sepsis, purulent process, and in the very beginning of inflammatory process. Neutrophils, elevated, infections or infectious processes, inflammation of internal organs, metabolic disorders, oncology, after vaccinations, receiving certain immunostimulatory drugs, reduced infectious diseases, blood disorders, hereditary disorders, following radio or chemotherapy, and due to the use of certain medications. Leukocyte formula. Neutrophil shift towards young forms, sometimes referred to as the left shift. Infectious inflammatory processes, acute blood loss. Such infectious diseases as diphtheria, scarlet fever, typhus fever, pneumonia, sepsis, and various intoxications. Neutrophils shift towards mature forms, or a right shift. Poisoning by radioactive substances. Irradiation, B12 deficiency anemia, lack of folic acid, chronic lung disease, obstructive bronchitis, probably also chronic. Lymphocytes, elevated for viral infections, including acute respiratory viral infections. Blood diseases, Saturnism, arsenic poisoning, use of certain medications, reduced in tuberculosis, lupus erythematosus, anemia, oncological disorders, renal insufficiency or failure, AIDS, radio and chemotherapy, so post-radio chemotherapeutic procedures. Monocytes, elevated in infections after acute inflammation, tuberculosis, especially certain forms of tuberculosis, brucellosis sarcoidosis, diseases of the blood system, phosphorus poisoning, reduced in anemia, leukemia, purulent lesions, post-surgery, and if receiving steroids. Erythrocyte sedimentation rate. ESR is increased by any cause or focus of inflammation. ESR is increased in pregnancy as well, in anemia or rheumatoid diseases like rheumatoid arthritis, lupus, rheumatic fever. Basal ESR is slightly higher in women, although it is virtually the same for small children, whether they are female or male. ESR is decreased in polycythemia, sickle cell anemia, hereditary spherocytosis, and congenital congestive heart failure, though this difference will not be evident in very small children, as their normal can be anywhere from 0 to 2. Let's focus now on the pathology. Diseases of the blood. They can be divided into 3 basic categories. Bleeding disorders or hemorrhagic disorders. Examples: hemorrhagic disease of newborns, coagulopathy, thrombocytopenia, thrombocytopathy, vasopathy. Anemias. Anemias can be classified into deficiency, hemolytic, post-hemorrhagic, and aplastic. And oncological blood disorders, which can be classified as leukemia or leucosis, lymphoma, and myeloma. Hemorrhagic diseases. Hemorrhagic disease of newborns, vitamin K deficiency, mostly associated with preterm children. Thrombocytopenia, or idiopathic thrombocytopenic purpura, also known as the Werlhof's disease. Vasopathies, hemorrhagic vasculitis. There are many hemorrhagic vasculitises. One such representation of a more or less common hemorrhagic vasculitis is the Schönlein-Henoch disease. Coagulopathies, we have hemophilia, A, B, C, Stewart-Prower disease, pseudohemophilia. Thrombocytopathy, macrocytic thrombodystrophy, Bernard-Soulier disease, very rare. Glanzmann's thrombocythemia, also very rare. May-Hegglin anomaly, also very rare. And von Willebrand's disease, more or less common from this group. Let's focus specifically. Hemophilia. Hemophilia is a group of hereditary genetic disorders that impair the body's ability to control blood clotting or coagulation, which is used to stop bleeding when a blood vessel is broken. Hemophilia A is the missing of the factor VIII. It's deficient, and this is the most common form. Hemophilia B, we have deficiency of factor IX. And hemophilia A and B are sex-linked, which means they are linked to the X chromosome. They need to be, it's a recessive gene, which means that two X chromosomes have to be both containing the recessive gene for hemophilia in order for a girl to be sick. However, for a boy, you only need one X chromosome. That's why most of the diseases we find in men, while women are the carriers and do not manifest symptoms or any significant symptoms, and homozygous females are extremely rare. There is also hemophilia C, which is a non-sex-linked hemophilia, and it has a problem with the deficiency of factor 11. And it's not X-linked, so it can manifest in both men and women. However, it is quite regional and is mostly limited to Jews of East European descent, and is quite rare or practically absent, sporadically present in other population groups. When a blood vessel is injured, a temporary scab does not form, but the missing coagulation factors prevent fibrin formation, which is necessary to maintain the blood clot. A hemophilic does not bleed more intensely. Despite the name, despite some of your assumptions, a patient with hemophilia will not bleed out faster, will not bleed out more intensely than any other person without the disease. The problem is that bleeding typically lasts much longer. It doesn't stop, right? It's not a problem of profuse bleedings, it's a problem of clotting, of stopping the blood loss. And a minor injury can result in a significant blood loss and bleeding that can last for days, weeks, or even never completely healing. This can be fatal or debilitating if this happens inside important organs, such as the brain. It can also happen inside joints, leading to what you see in the pictures, a condition known as hemarthrosis, that can cause severe deformation of joints. And if multiple bleedings occur over time, it can lead to permanent destructive changes inside the joint and complete loss of joint function, disability. One of the main features of hemophilia is what's called also late bleeding, where the person injures his, let's say, knee, but the bleeding doesn't begin immediately. It begins delayed after some time. This can happen for surgeries or tooth extractions. Delayed bleeding can give a false sense of security that everything is okay, and the patient will start bleeding later, possibly causing lethal complications. How to recognize a bleed? Look at this chart of how you can inform patients that have hemophilia about how to recognize a bleed in themselves. Symptoms of head bleed. headache, drowsiness, nausea, vomiting, steady balance, irritability, confusion, seizures, loss of consciousness, abdominal bleeding, bloody black or tar-like bowel movements, red or brown urine, pain, vomiting of blood, joint or muscle bleeding, tingling, pain, redness, swelling, warmth, tenderness, reluctance to move the affected limb. Idiopathic thrombocytopenic purpura. This is defined as an isolated low platelet count, so thrombocytopenia, with normal bone marrow and the absence of other causes of the thrombocytopenia. The function of thrombocytes may be reduced from the beginning or diminish with time as the thrombocytes are reduced and younger forms of thrombocytes with lowered function enter the bloodstream. It causes a characteristic purpuric rash and an increased tendency to bleed. Idiopathic thrombocytopenic purpura is an autoimmune condition with antibodies against the platelets, antigens that can be detected in the blood. Two distinct clinical syndromes manifest as an acute condition in children and a chronic condition in adults. The acute form often follows an infection, has a spontaneous resolution within 2 months. Chronic idiopathic thrombocytopenic purpures persist longer than 6 months, with a specific cause being unknown. Wiskott-Aldrich syndrome. This is a rare X-linked recessive disease characterized by eczema, thrombocytopenia, immune deficiency, bloody diarrhea, secondary to the thrombocytopenia. Also known as eczema, thrombocytopenia, and immune deficiency syndrome. The disease occurs only in males. The first signs of Wiskott-Aldrich are usually petechia and bruising resulting from low platelet count. Spontaneous nosebleeds and bloody diarrhea are common. Eczema develops within the first months of life. Recurrent bacterial infections develop by 3 months. Enlargement of the spleen is common. Majority of Wiskott-Aldrich children develop at least one autoimmune disorder, and cancers, mainly lymphomas and leukemias, develop in up to a third of patients. Immunoglobulin M levels are reduced. Immunoglobulin A and E are elevated, and IgG levels can be normal, reduced, or elevated. Schönlein-Henoch purpura. You see a characteristic purpura rash on the lower extremities and buttocks, usually beginning from the bottom and going all the way up. Here you see them going on his sides and even on his arms. Schönlein-Henoch purpura is considered a systemic vasculitis, inflammation of blood vessels or intimal blood vessels, and is characterized by deposition of immune complexes containing IgA antibodies. The exact cause is unknown, but there are links to multiple various conditions and triggering factors. So in this case, the disease affects skin and other organs, but most commonly in the skin, the disease causes palpable purpura, small hemorrhages, often with joint and abdominal pain, leading to the articular syndrome and the abdominal syndrome. In about a third of the cases, we see involvement of kidneys, manifesting as glomerulonephritis, with blood and proteins in the urine. And this may transform into a chronic form of glomerulonephritis. Schönlein-Henoch purpura is often preceded by a throat infection, usually strep throat, streptococcal pharyngitis, perhaps beta-hemolytic streptococcus group A. Usually resolves within several weeks and requires no treatment apart from symptom control, but may relapse in a third of the cases and cause irreversible kidney damage and the appearance of chronic glomerulonephritis. May-Hegglin anomaly. This is a rare congenital disorder, also known as dull leukocyte inclusions with giant platelets and macrothrombocytopenia with leukocyte inclusions. This is an abnormality of the platelet cells, more specifically certain structures inside their membranes, where the cell breaks off from the main megakaryocyte but at a very large size. The cells are large and are dysfunctional. Their properties of adhesion aggregation are reduced, leading to presentation of a hemorrhagic syndrome. Von Willebrand's disease, this is a fairly common disorder as far as hemorrhagic diseases are concerned anyway. Although it can also be acquired as a result of certain medical conditions. It arises from a quantitative or qualitative defect of von Willebrand factor. This is a protein that is required for platelet adhesion. It has several types. There's type 1, 2A, 2B, 3, vascular type, and thrombotic types. And in a lot of patients, it's actually asymptomatic unless there's some serious significant bleeding. Another couple of rare syndromes, Bernard-Soulier and Glanzmann's thrombocytopenia. Bernard-Soulier, also called the hemorrhagic thrombocytic dystrophy, rare autosomal recessive coagulopathy. It's caused by deficiency of certain structural proteins of the membranes of thrombocytes. And the receptor for the von Willebrand factor, characterized by abnormally large platelets and, of course, reduced quantity and functionality of platelets as well. Glanzmann's thrombocytopenia, it has abnormality of thrombocytes and white blood cells, extremely rare coagulopathy in which the platelets contain defective or low levels of certain glycoproteins, and which are the active receptors for fibrinogen. As a result, no fibrinogen binding of platelets to other platelets can occur, and the bleeding time is significantly prolonged. Here's some bruising for Glanzmann's thrombocytopenia, but also can be interpreted for any thrombocytic anemia or pathy. Anemias. Anemias is a quantitative deficiency of hemoglobin, which is often accompanied by reduced number of red blood cells. We have deficiency in megaloblastic, which is a folate deficiency or B12 deficiency, microcytic iron deficiency, protein deficiency, aplastic hereditary total lack of hemopiesis, such as anemia of Fanconi, Strang-Domestic, focal lack of hemopiesis, such as Diamond-Blackfan, aplastic acquired post-hemorrhagic acute and chronic, such as iron deficiency, would be a chronic acquired post-hemorrhagic. Hemolytic hereditary includes membrane defects such as microspherocytosis or other similar situation, acanthocytosis, stomatocytosis, enzyme defects such as deficiency of glucose 6-phosphate dehydrogenase, porphyrin defects such as vampirism, nucleotide defects, hemoglobin defects such as thalassemia and sickle cell anemia. Hemolytic acquired include isoimmune, hemolytic disease of newborns, autoimmune, mechanical artificial heart valve damage, chemical such as lead poisoning, and parasitic such as malaria. Symptoms of anemia include possible yellowing of the eyes, fatigue and dizziness, for severe cases fainting, low blood pressure, paleness, coldness, or yellowing of skin, respiratory, shortness of breath, muscular weakness, intestinal change of stool, heart, palpitations, rapid heart rate, in severe cases, chest pain, angina, or heart attacks, and enlargement of the spleen. This is for all anemias, without specifying which one we're talking about. Obviously, such symptoms as yellowing of the eyes of the skin are more typical for hemolytic anemias or B12 deficiency anemias, while severe muscular weakness are more typical for iron deficiencies. Diagnosis of anemia by severity. Mild anemia, 120 to 90. But here it states 110. This is to specify for small children below the age of 6, because if you remember their normal it's less than 120. They have the physiological anemia. Number of erythrocytes, 3.5 to 3. Again, this can be a normal in very small children. And remember that erythrocytes alone do not mean anemia. Anemia is not the same as erythropenia. Anemia is the decrease of hemoglobin. Yes, it is very often accompanied by decrease of erythrocytes. But decrease of erythrocytes by themselves without hemoglobin decrease do not imply anemia, simply erythropenia. Moderate levels 90 to 70, 3 to 2.5 erythrocytes, and severe anemia below 70 and below 2.5 erythrocytes. Calculation of the color index, I promised to show you. Here it is. It can be calculated as the level of hemoglobin in grams per liter multiplied by 3. So for instance, if our hemoglobin is 120 multiplied by 3, that's 360, divided by the first three numbers, first three digits of erythrocytes. If erythrocytes are 3.6, then we will use 360. Okay? If we divide 360 by 360, our color index will be 1. Normally, color index is between 0.85 to 1.05. Physiologically, it's possible to get numbers up to 1.15. Clinically, this can only happen in newborn infants. In children in pediatric medicine, depending on the age, these reference values can be expanded to 0.8 and 1.1 to determine whether or not the person has hypo or hyperchromia. Alternatively, again, I will mention that MCH and MCHC can also be used to make the same conclusions. Minkowski-Chauffard anemia. This is the congenital microspherocytic anemia. The erythrocytes are not flat, they're little tiny spheres. The disease is characterized by the appearance of several crises, such as the aplastic crisis and hemolytic crisis. It is also characterized by the enlargement of the spleen. And of course, anemia. Sickle cell anemia, this is a very specific type of poikilocytosis that appears with the changes of the cell structure. With sickle cell anemia, the patients manifest the same type of crisis that they do in congenital spherocytosis, which is the hemolytic and aplastic crisis, but also they manifest other crises, such as the vaso-occlusive crisis due to the misshaped erythrocytes blocking blood vessels, and the sequestral crisis, which occur in infants due to the centralization of blood perfusion, can lead to lethal consequences. It's also probably interesting to note that patients who have sickle cell anemia, and it's not severe form, have a fairly good immunity to malaria, as the malaria plasmodium cannot replicate inside sickle cells. Thalassemia, another congenital hemolytic anemia, characterized by quantitative hemoglobin changes in the alpha and beta chains of hemoglobin, resulting in possible alpha and beta thalassemias. By the way, these patients are also resistant to malaria. However, homozygous thalassemia patients exhibit multiple phenotypical signs of internal defects, especially defects of bone structure. The homozygous thalassemia, also known as the Cooley disease. Leukemia. Leukemia is a blood carcinoma. It's caused by the rapid production of immature white blood cells that are not able to fight infections. They impair the ability of the bone marrow to produce red blood cells and platelets. Leukemia can be either acute or chronic. Leukemia is also classified as lymphocytic or myelocytic. Lymphocytic leukemia refers to abnormal cell growth in the marrow cells that become lymphocytes, the lymphoid progenitors, as we've seen in the first slides. In myelocytic leukemias, abnormal cell growth occurs in the marrow of cells that mature into red blood cells, white blood cells, and platelets. There are four broad classifications of leukemia. We have acute lymphocytic leukemia, acute myelogenous leukemia, chronic lymphocytic leukemia, and chronic myelogenous leukemia. Acute lymphocytic leukemia is the most common form of leukemia in childhood. Acute myelocytic is the second most common. Common symptoms of leukemia: physiological fatigue, loss of appetite, lymph node swelling, spleen and liver enlargement, hepatosplenomegaly. Skin shows signs of night sweating, easily bleeding and bruising, hemorrhagic syndrome, purpurish patches or spots. Bones or joints may exhibit pain or tenderness, muscular weakness. Lungs, shortness of breath, and systemic weight loss, fever, and frequent infections. Lymphoma. Lymphoma is a type of blood cancer that affects the lymphatic system. Abnormal lymphocytes, a type of white blood cells that fight infections, become lymphoma cells, which multiply and collect in the lymph nodes. Over time, these cancerous cells impair your immune system. Lymphomas are divided into two categories: Hodgkin's lymphoma and non-Hodgkin's lymphoma. About 12% of people with lymphoma have Hodgkin's lymphoma. Because of breakthroughs in research, this once fatal diagnosis has been transformed into a curable condition. Most non-Hodgkin lymphomas are B-cell lymphomas and either grow quickly, high grade, or slowly, low grade. There are 14 types of B-cell non-Hodgkin lymphomas. The rest are T-cell lymphomas named after different cancers of the white blood cells or lymphocytes. One of the main diagnostic features and pathomorphological structures that appears in cases of lymphoma, more specifically Hodgkin's lymphoma, also known as lymphogranulomatous, is the giant cells known as Reed-Steinberg cells. They're found in bioptic material from lymph nodes. The best type of biopsy to confirm the lymphoma is called an open biopsy, where the lymph node itself is taken out for morphological study, while the puncture biopsy is more considered of a screening method and less of a confirmatory method. Bone marrow investigation, biopsy from the bone marrow, and the subsequent myelogram can also be used, especially to differential diagnose lymphomas from leukemias. Myeloma. Myeloma is a cancer of the plasma cells. Plasma cells is what you've seen in the very beginning. It's what the B cells mature to, right? The B lymphocytes mature to produce antibodies. Myeloma cells prevent the normal production of antibodies, leaving your body's immune system weakened and susceptible to infection. The multiplication of myeloma cells also interferes with the normal production function of red and white blood cells. An abnormally high amount of these dysfunctional antibodies in the bloodstream can cause renal damage. Additionally, the myeloma cells commonly produce substances that cause bone destruction, leading to bone and/or bone pain and/or fractures, spontaneous fractures. Myeloma cells are produced in the bone marrow. Sometimes myeloma cells will travel through the bloodstream and collect in other bones in your body. Because myeloma frequently occurs at many sites in the bone marrow, it is often referred to as a multiple myeloma. When it collects in the different parts, in the different bones of the body, such as the bodies of the vertebra, it can damage its physical structure, weakening it significantly, causing compressional fractures of the vertebra, leading to significant medical problems. That's all. Thank you.